including my commentary, I was able to review this video in an hour and a half, and the video itself is an hour and a half. Because we watched it at double time, that allowed me time to make my comments, even though we're still within the exact same time frame, precisely an hour and a half of the original video. So I think this worked. I'll try to do this again in the future. Good morning, everybody. Today's the third day of January 2024. And like I said, I believe yesterday on the blog, my plan for this year is to focus more on pain management because I have the intention of refreshing my previous publications on migraine, fibromyalgia, and chronic pain. Actually, the section on chronic pain will be entirely new based on some of my personal experiences over the last couple of years. So, and obviously the science that has developed in that much time. So, consistent with my goal of focusing more on chronic pain this year, I had the idea the other day that I'm going to try to integrate at least one article per day for, let's say, 3 months. And I don't know if that's actually possible because we have some trips planned and some other things obviously will happen in that much time. But let's say 100 articles integrated into the new material before I publish it again. That would be pretty reasonable and certainly worthy of an update. So consistent with that, I'm going to try to look at something every day and integrate that into the book. And it could be an article, like I just said, or in this case, it could be a video. So last night, right before I went to bed, for whatever reason, thanks to the YouTube algorithms, this video came up on my feed, and I didn't watch it because it was too long at that hour, but I did save it obviously for today. And so right now I'm going to go through this video called The Science of Pain Management that was published by Harvard Medical School 5 years ago. So this was 2018 according to the date, I believe, that's on the page. Let me just take a look at it since we're here. So this was March of 2018. So in that case, that makes it almost 6 years ago. But still, 2018, as I mentioned in yesterday's post, 2018 was somewhat important in the sense that one of the most common chronic pain conditions, migraine, received a whole new batch of drugs. Now, how in the world do these drug companies coordinate the release of novel drugs at the same time? So, theoretically, in the so-called free market model, a drug company would innovate in a way that would obviously be different from its competitors. But what we see in the drug companies is they innovate, and then within the same time frame, a bunch of companies have the same product, basically. So the point is, for all of you who love the idea of free market capitalism, is that it's just a sham. Free market capitalism is just a lullaby to make people fall asleep and go for this model of stupidity, basically. But anyway, in 2018, a bunch of drug companies simultaneously invented this same line of drugs, just like they did with the injections for the pandemic. All of a sudden, all of these companies came out with the same platform, targeting the same molecule for the same infection, and we're supposed to believe that that was spontaneous. But anyway, we're going to get back to this topic of pain management. I'm going to go through this, and I'm going to write my notes as I'm going through this, so you'll see the notes that I'm kind of writing to myself. And I expect that, let me say this slightly differently. The way I want to say this is, it's going to be a winning situation. So I'm creating a winning situation here for myself, and hopefully for you as well. And here's the way that I'm structuring this winning situation. Either they're going to say things that are good, so I'm going to call that positive science. So either they will say things that are good and reasonable, and we will collectively get to learn from that, or they're going to say stuff that is so absurdly stupid, I'll call that negative science. They'll say things that are so stupid, and then we'll get to comment on that. And that's, I suppose in some way that's how my books get written, especially on fibromyalgia. Well, on psoriasis as well. It's a combination of what I consider to be positive science. So what does the science actually say? But the other part of it is what I call negative science, and that is just this mountain of bullshit that comes out of these so-called elite universities that's just designed to create medical drones that just pass out pills without any understanding of what's really going on. So through positive science, I get to build competent protocols. Through negative science, that pisses me off. That kind of fuels my anger to get this stuff done and keep working and keep publishing. So either way, this is going to be a winning situation. So I'm going to watch this video. I'll type a few notes and make comments along the way, of course. I'll try to keep it brief because this is an hour and a half long. So I'll probably be sitting here for at least 2 hours doing this. But one way that I can speed that up, I'm going to play this back at 150% speed. So that'll save us some time. If that turns out to be too fast, then obviously I can slow it down. But in order to get through this as fast as possible, I'm going to speed it up and at least the video playback. And like I said, I'm going to type my notes. I'll try to get through this as fast as possible with maybe not making every comment that I want, but making the comments that I think are really important. And we'll see how this goes. I've never done this exactly in this format, so we'll just see how it goes. But I'm hoping that we get to learn something positive, or if not, then we get to be repulsed by the absolute stupidity of what I expect they're going to represent here. So, but let's just see how it goes. So this is called The Science of Pain Management. Published in this was produced in 2018. So again, I had published Inflammation Mastery in 2016, and I published my first book was an orthopedics review, mostly for chiropractic and naturopathic clinicians and students. So, and I've written other books and articles on pain management. So I think I have some expertise here. And we're going to see how my expertise compares to what they say. And let's see if they say anything worth hearing. But anyway, let's get into it.
Hello, good evening. We have quite a few people still waiting to enter. We have a tremendous turnout tonight, but we'd like to get started. I'm Gina Vild. I'm the Associate Dean for Communications and External Relations at Harvard Medical School, and I am so thrilled. This is my 10th year introducing the Longwood Seminars, and I'm just delighted to see so many familiar faces and some new faces in our Longwood Seminar family. So tonight's topic, the science of pain management, is of tremendous interest to many of you. We choose our topics by having our Longwood Seminar audience vote, and this was definitely a topic for which there was great interest expressed. We're going to talk about the science of pain and how to manage pain, both temporary and chronic. And we're also going to discuss how managing pain has become, unfortunately, a national health crisis. We recognize that this issue touches many lives throughout the country. And so as a result, we're going to provide you with even more information than what you'll garner tonight on opioids and addiction. On a slide that will be on the screen soon, there are 3 additional resources. First, you'll find a wealth of information offered by Harvard Health Publishing. It's content for consumers and clinicians, and I invite you to take a look at this site because you'll find information on addiction and pain, but also information on diet and health and a whole range of topics. Second, last year, we brought together some of the country's leading experts to discuss how education can combat addiction. They included Governor Charlie Baker, who led the governor's opioid addiction working group, and Harvard's own Dr. Bertha Madras, who you will hear from tonight. The program was viewed by tens of thousands of people around the world, and we invite you to view it as well, and that website also is on the screen at hms.harvard.edu/opioids.
So she's just talking about resources, but she talked a little bit about health and nutrition or diet or something like that. I would have zero faith in anything that Harvard puts out, but they are still, a leading voice, not through competence, but through influence. And that's why we're going to pay attention to this right now. She just said that they've had tens of thousands of views.
A third resource was a talk given at Harvard Medical School last year by, again, one of tonight's speakers, Dr. Clifford Wolf. It had an outstanding attendance. It was standing room only, and we invite you to take a look at it. It's the link hms.harvard.edu/talks at 12. I want you to know that in addition to those who are here in the auditorium, we're welcoming thousands of you from throughout the world. So thank you for joining us through the live stream. 2 weeks ago, for the last Longwood Seminar, we had 30,000 people joining us virtually from 82 countries. So to those who are here in person and those who are here through live streaming, welcome. We hope you'll join us for the next 2 Longwood Seminars, Bridging East and West, New Frontiers in Medicine on April 12th, and Weighing the Facts of Obesity will be held on May 9th. Now, just a few brief announcements, and we'll get on with our program. Our speakers are delighted to take your questions tonight, so please write your questions down on the card you were given, and our staff will be walking up and down the aisle, and they will collect those. If you are watching through the live stream, you can write your question in the feed, the Facebook Live comment box, and we will try to feed those questions to our speakers as well. On the screen, you'll see information related to obtaining certificates of completion and professional development points for teachers. Okay, and we also invite you to visit the Longwood Seminars page on the HMS website, where you can find past seminars and watch those from previous years. Many of them are evergreen topics. Now we ask you to please sign.
Well, thank you very much. It's a great pleasure to be here. Gina did the great introduction.
Okay, so this guy, James Rathmel, is a medical doctor. He's going to talk about the science of pain and its management. He's the chair of the Department of Anesthesiology, Perioperative, and Pain Medicine. And he's got an endowment from Leroy Vandam to be professor of anesthesia at Harvard Medical School. Okay, so let's see what this guy's got.
And she made the quintessential mistake, the one that I have over and over throughout my career, of mistaking me for somebody 20 years younger. So thank you. It's a great pleasure to be here. No mic. There we go. Thank you. All right, microphone. So I'm going to talk tonight about the title, The Science of Pain Management. And I put my title a little bit differently, The Science of Pain and Its Management, because the two haven't connected very well yet. We know a whole lot about the science, thanks to some of the people you're going to hear from tonight. And I'm going to tell you a little bit about the management and some of the things we've been through that probably don't work as well as we had first thought they would. I am a chronic pain specialist by training. I've been in this 25 years. I also practice anesthesiology in the operating room as part of my...
So he's a chronic pain specialist for 25 years.
My role is the chair of the department there. So I'm very much involved every day in the management of pain.
And the chair of the department. So bring it on, man.
Surgery and injury, as well as those who go on to have persistent pain that lasts for long periods of time. So like any good teacher, I want to tell you what I'm going to teach you, and then at the end, I'm going to tell you what I just taught you. So we're going to start with what are the things I want to get across. They're really pretty simple. I want you to be able to define what pain is and explain why we have pain. What's its purpose, physiologically? I want to describe you to be able to describe the differences between acute pain, chronic pain, and then this special subset of chronic pain we call neuropathic pain, because it's important to recognize and the treatments can be very different. I want to talk about how opioid analgesics work to relieve pain, because they do work, and they do have a very prominent role in our armamentarium. But then I'm going to go on and talk about why opioid analgesics are important in the care of acute postoperative pain, but they remain very controversial and are getting more controversial in the treatment of chronic pain, and where that problem comes from. So let's start out with what is pain. So this is the definition, and it's put forward by the International Association for the Study of Pain. It's the biggest international group of clinicians and researchers that have been working at this for decades. And this is the definition they put forward in 1986. Pain is an unpleasant sensory and emotional experience, because there are both components to it, and both are very, very important, that are associated with actual or potential tissue damage or described in terms of such damage. So when you read this definition, it's really important to understand that we as clinicians don't know what you're experiencing. We don't know either the physical experience or the emotional experience or how they're tied together. All we know is what you're describing to us. And so we take it at face value. We come in, we take it at face value, and we move forward from there. It is not measurable. We do not have the magic algometer, although there's lots of work going on in that area. So if you're one of those people who is very innovative, develop an objective measure of pain, and you will do very, very well. So here's the wiring, the physiologic wirings from one of my textbooks early on. So pain, what is it and why do we have it? Now think about this. You put your hand on a stove. You immediately pull away. There's a reflex arc that says, get that out of there. And then you start to feel this burning sensation where you've suffered injury. If you touch that area, now remember, before you put your hand on the stove, if you touch the area, it feels like normal, light touch, right? Doesn't bother you at all. Now you pull it off of the stove, tissue's been injured, and almost immediately you have a sensitization. Now you touch it, light touch hurts, right? It's painful. And Dr. Wolf, early in his career, worked out the anatomic correlates at the level of the spinal cord. We actually increase the gain of a normally light touch, and it's called spinal cord wind-up. That is the sensitization that occurs. And why does it occur? Now think about that. You've just injured yourself. And what the physiology and the rewiring that immediately says, protect that area. Protect it, it's injured, tissue healing has to ensue, and if you keep using it, if you keep re-injuring that same area, it won't heal. And we know that because if in those who are born without the sensation of pain, or in those who lose it, like in damage to the peripheral nervous system that occurs in diabetic neuropathy, they'll injure the same area over and over and over, and they'll end up with open wounds that don't heal and amputations. And that's the important part of this. The other part is, so it comes into the spinal cord level, goes across the midline up to the brain. The important part about the way analgesics work is we can dampen that input. So you see that modulation, that descending limb that comes down to that first order neuron. So I guess I should orient you here. Out in the periphery where the flame is, that's your hand. And then it comes to the spinal cord, which is the central part. There's a very specific area in the spinal cord where that first order neuron comes in and relays the signal up to your brain where you perceive pain. The modulation comes from the central nervous system downward to the spinal cord and says, we can reduce that input so that it's not as severe. We can dampen it down so that you can still function in the face of pretty severe injury. So that's the function of pain, protective. Now what about the different types of pain? So we have acute pain, and acute pain signals tissue injury, just like I told you. It says keep it protected until all of the tissue heals. But at some point, in states where you have recurrent tissue injury, or in those where you've had permanent alterations of the nervous system, you can have pain that persists 3 months, 6 months. There are different definitions, but by and large, beyond 3 to 6 months, we call it chronic pain. And chronic pain can come from a recurrent condition that injures tissue over and over. It can have a waxing and waning pattern, or it can be chronic, persistent, and severe that never lets up. There are many different types of pain, but what underlies it is what is the cause of the tissue injury. Now, there's a special subset of pain that happens when you injure the nervous system, and it's frighteningly common after injury. When you injure the nervous system, sometimes all the tissue injury heals. If you look at the person, if you look at the area that was injured, it looks normal. All of the tissue is healed, but there's persistent pain in that same distribution. We call that neuropathic or abnormal pain associated with nerve function. And there are many different types. You think about tic douloureux, those sudden shooting pains into the face that can occur with stimulation of the trigeminal nerve, just these sudden lancinating pains. Hypersensitivity, even in the area it looks like it's healed. We call those neuropathic pain. And it's important to identify because the treatments are very different for nerve injury pain than for normal pain after illness or injury, that acute pain. All right, so now how is pain treated? Now the science, we diverge from the science a little bit here. So we call pain-relieving drugs analgesics. It's an agent that produces a diminished sensation to pain without loss of consciousness is the actual dictionary definition. And it comes from the Greek algos for pain and an without, analgesia or analgesics. So we're going to talk about a number of different analgesics. Now, first of all, when we approach a person who has any type of pain, remember this is a 20-minute talk, we're not going to get to all different types of pain, but maybe we can entertain specific questions at the end. Pain treatment always begins with identifying the underlying cause. Absolutely critical to identify the underlying cause. And then you can tailor the treatment to the cause of the pain by knowing the expected duration of the pain and what the magnitude of that pain is based on what the patient is telling you, the person that's suffering from the pain is telling you. We use analgesic drugs in a variety of different forms, but it's a really small part of managing patients with pain. I had a person in the Harvard system come up to me at the beginning of this, Carol Martin, came up and told me a little bit about her story and what she's suffering from. And she has focused completely, early in the course of her story, her journey, she was focused on pharmacologic agents and then transitioned to complementary and alternative medicine means studying a wide range of them that can be very, very effective for getting away from pharmacologic treatment. So I think it's important to understand that drugs are a very small part of managing pain overall. All right, but I'm going to focus for a minute on analgesic agents and their uses. Now here's the range of what we have out there. And it begins with acetaminophen. It's a very good analgesic. We don't know exact mechanisms. We have some ideas of where it works in the central nervous system. It's different than the other drugs like ibuprofen, which we lump into a class called nonsteroidal anti-inflammatory drugs. Turns out they're very effective pain relievers for mild to moderate pain, and they really form the cornerstone of management of pain after sports-related injuries, strains and sprains and the like. There's a group of atypical analgesics that work in different ways on different receptors, but have pretty good analgesic effects, and tramadol is one of those you might have heard about. Then there are neuropathic agents that work better for neuropathic pain, those nerve injury pains, than they do.
So I'm going to stop the roll here for just a second, just so I can type out my notes. But you can see how completely non-innovative this guy is already. And I realize he's just getting started. But, and maybe this is why he has his job as being chair, but he's just repeating stuff. I mean, everything he's said so far, you could have gotten out of the Merck manual 30 years ago. And that's probably, I don't know, I don't want to insult him, but maybe that's where he got his education, was just reading the Merck manual. I mean, this is exactly what I didn't want to see. He's just babbling back the same medical, I mean, he's the chair of this department at Harvard Medical School and he's been a professor or expert on this topic for 25 years, he says. And so far he's just repeating, I mean, this is just medical babble. So I'm going to take my notes, and I think while I'm typing out my notes, I'll try to avoid talking, so then I can compress that section of the video so it'll go faster. And you don't have to, watch me type this stuff out, but so far this is really boring. And I appreciate that he probably obligatorily had to go through some review of, basic anatomy or something, but we'll see where he goes with it. He did go through this. This is what I've for 20 years now, because I'm thinking of a presentation I gave back in 2004. This is the Cartesian model, basically. I mean, this is accurate anatomically, but it's still based on the Cartesian idea of sensation and pain and all this kind of stuff. So, should he have presented this image? Yes, it's appropriate to do so, but let's hope he doesn't solely rely on that image. So let me take a quick few notes here, and then we'll keep moving on the video. I am playing it back at double speed because otherwise this would be really painful. Unfortunately, double speed is as fast as I can get it to go. If there was a 3x or a 4x, I'd probably use that as well. But anyway, let me just take a few notes here. So I'm just going to comment very quickly on acetaminophen. He also said, and I think this is well known, that the exact mechanism of acetaminophen is not known, but it's still commonly used. And so the only thing I want to point out about that is that in the world of nutrition and integrative therapeutics, the medical world, the medical profession will often say, oh, well, these interventions don't have a known mechanism, or the science isn't clear, or whatever. And they use that to attack non-drug treatments. But if the same thing applies to a drug treatment, like in this case, they're saying he's repeating what is well known, and that is the exact mechanism of acetaminophen is not known, then somehow that's okay. So if we don't know the mechanism for a drug, then that's okay. But if we don't know the mechanism for a nutrient, then that's a reason to not use the nutrient, according to the medical paradigm. So the other problem that he's presenting is exactly in his method of presenting this. You can tell where he's going to go with this conversation. And he's only one speaker in this panel, apparently. He said it was going to be 20 minutes. But again, these are all old school interventions, and apparently he's going to limit his conversation to these interventions.
That work in different ways on different receptors, but have pretty good analgesic effects, and tramadol is one of those you might have heard about. Then there are neuropathic agents that work better for neuropathic pain, those nerve injury pains, than they do for acute pain, and gabapentin is the best known of those. Then we have an alternative group of drugs that we use in various ways, either topically or by injection. The local anesthetics, they actually work in a completely different way. They block sodium channels, and you get no conduction of the nerve traffic for a good long period of time. We all know that. Lidocaine is the prototypic one now, but the one people know best is by its brand name Novocaine or Procaine. That's used by dentists early on. It's not used much anymore because of sensitivity reactions, and lidocaine is the more common one. It doesn't work for long periods of time, and it completely gets rid of all sensation, so it's very difficult to protect an area that's been anesthetized with a local anesthetic, and that limits their long-term use. And then finally, we're going to talk about opioid analgesics, which is where a lot of this controversy has come up. And the quintessential one, or the prototypic one, is morphine that people know best. All right, now let's talk about opiates and opioids. Opiates are drugs that are derived from the dried latex of the oriental poppy. Now, this is actually a northern poppy from my backyard up in Vermont when I lived there several years ago. The oriental poppy, that's Papaver somniferum, has a very large seed pod. It's set in the middle. When, at the end of the growing season, the petals fall off, you can score that seed pod, and a latex drips out. And it has a number of different compounds in them, morphine being one of them, but a number of different alkaloids that can be extracted. Opium, or tincture of opium, is the raw black tar that dries in the sun. And this has been around a long, long time. Its use dates back thousands of years. Okay? Opiates, the difference between an opiate and an opioid. Opiates come from the poppy plant, and opioids are either synthetically or semi-synthetically derived. And fentanyl is the one in the news. It's an opioid. It's a synthetic opioid that's made in the laboratory that binds to the same receptors. But morphine and fentanyl work in very much the same way. Their potency is incredibly different, so you need a lot less fentanyl to do the same thing as a much larger dose of morphine. So how does it work? Here's the mechanism of action of this drug, and I've showed you that first incoming neuron at the level of the spinal cord, and then there's a blow up here. We know the neurotransmitters and the ion channels where these medications bind, and what they do is bind at the level of the spinal cord and in the brain, and they decrease the magnitude of the incoming traffic. And they're a beautiful system. We have endogenous opioids that are released in the face of danger that bind to the same receptors, and they allow us to function. But it's not like a local anesthetic. You can still feel where the area has been injured. It's just the magnitude of the pain is decreased. So one of the important things to remember with the opioids is you never completely get rid of pain until you reach unconsciousness at very high levels. All right, so what are the side effects of the opioid analgesics of this specific class? So very common side effects. Almost universally, they can produce nausea, vomiting. When you take them for long periods of time, they decrease the motility of the gastrointestinal tract and you get constipation. Itching is very common with it, pruritus, sedation at higher doses. And what we fear most in overdose is respiratory depression. You stop breathing. And I have mouth-to-mouth, a little diagram of mouth-to-mouth. Turns out, we as anesthesiologists often use large doses of these, and respiration stops in the operating room. But we have mechanical ventilation at hand. We can breathe for you during the period of surgery. Opioids are very good in high doses. They're very easy on the cardiovascular system, and they form the cornerstone of very stable anesthetics for things like cardiac surgery. But we have to be there as anesthesiologists to breathe for you. So if you take a very large dose and overdose, and there's not someone there at hand, or you're not there to help breathe for your colleague, then brain death ensues within 5 to 7 minutes, okay? Now, it turns out that sedation comes first, and most people get a level of sedation, but their heart's still pumping. They're not responsive. And that's why naloxone has been so helpful. Naloxone is a pen or a nasal spray. If your heart's still beating and it can circulate, that's actually blocks the receptor where the opioid binds and completely reverses all of the depression. It's really kind of miraculous when you get patients wake up, or a person wakes up immediately. So what's the big controversy about opioid analgesics? They're really good pain medications, particularly in the postoperative period. They work. They work universally. As an anesthesiologist, I could not get through the day helping people with their postoperative pain without these. This is written by Thomas de Quincey at the turn of the 19th century. He was the son of publishers in London. He wrote a 3-volume set called The Confessions of an English Opium Eater. And in the final volume of this set, there's a chapter on, it was mostly about all the wonderful things he experienced in the drug-induced state, all of these wonderful insights into life. But the last chapter is about how opium gives and takes away. It tears at the fabric. It's very, very reinforcing. You come back oftentimes for the euphoric effects, not just the pain-relieving effects. We know that it has this potential, and it falls under addiction. So here are the 3 things we talk about. If you take an an opioid analgesic, morphine, over and over and over, you'll need higher doses to get the same degree of pain relief. That's a normal phenomenon. It's called tolerance, and we know how that occurs. If you stop it all of a sudden, you go through withdrawal, jitters and shaking and high heart rate. That's called physical dependence. Addiction's very different. And it's hard to summarize, but it's really when you lie, cheat, and steal simply to get access to that drug because of its reinforcing effects. And it's a disease of the brain. We know a lot about why it occurs. It's not a bad person that does this. It's a very physical reinforcing effect. What we worry about most, though, as physicians, is when we write this and the person takes that prescription and sells it on the street. Diversion. And that occurs, and we worry about that. Those are the downsides of the opioids. All right, now to finish up, is acute pain different than chronic? Chronic pain, I told you, 3 to 6 months or more. It's extraordinary. This is the Institute of Medicine's report in 2011, and it's 116 million Americans suffer with pain that persists beyond 3 to 6 months, and it can often be debilitating. Opioid analgesics are extremely effective for treating acute postoperative pain. I told you I could not get through the day without them. So it's important that we don't eliminate their availability. We would not be able to treat pain associated with illness, injury, at the end of life, very advanced illnesses, on obstetrics during labor and delivery. They're very important in that. But until recent years, we did not use opioids for treating chronic pain. It was very limited.
Okay. Well, he's saying that within his setting of hospital medicine, he has to use opioids. And that's probably mostly correct. But that's the mistake of the medical model, is they try to extend an acute care model into chronic care. And he apparently isn't going to differentiate between those two things.
Because we don't know about these terrible adverse effects, including the...
Right out of the gate, this guy seems to be positioning his presentation to support and defend the use of opioids. And that would be consistent with what we would expect from Harvard and any so-called elite school. Their job is to defend the interests of the power structure. And so if we have in the United States, and now throughout the world, if we have a population addicted to drugs, then the elite institutions have to defend that. So we have to declare it an emergency, and then we also have to defend its existence at the same time. And that's why things never seem to get better in the United States, especially, which, obviously I spent most of my life in the United States, so I'm more familiar with it. I don't really know the ins and outs of other countries as well. But in the United States, you see this all the time. We're going to declare something an emergency, and then we're going to block any progress from changing the conditions that lead to that emergency. And that's exactly what he's doing right now. And he's doing this from a position of his own experience. And again, it's within his experience of hospital medicine, he's probably correct, because he's treating acute patients, he's treating surgical patients. Yeah, opioids are probably okay in that setting, especially when they're on top of these patients with supervision, etc. But I would hate, and the reason I don't hate, I would hate the experience of thinking that I or someone else is a chronic pain expert, and this is all they know. This is basically all we learned in medical school about pain and medical training when I was working in hospitals. I mean, this is all we did. Everybody got acetaminophen. Everybody got opioids. I mean, this is horrible. He put himself in the position of talking about pain management, so I would hope that his life extends beyond these drugs, but let's see if it does.
Addictive effects of the medications. We thought addiction was very, very uncommon. Turns out it's more common than we at first believed, and some people are more predisposed on exposure to that than others. The science behind this has become more clear in the last several years, and this is the 2015 NIH workshop that centered on prescription drug abuse. The bottom line is there really is no science that suggests that long-term use of chronic opioids, particularly in high doses, is effective for treating any chronic pain condition. That's the stark reality of it. And as you go up in dose, a number of side effects appear with greater and greater frequency, including the risk of things like myocardial infarction and death from overdose as you get to higher doses, even if you're taking them for chronic pain. And that's very frightening and sobering to us. We're going to learn more about what that's done at the national level. So just to finish up, I want to summarize by hoping you can answer each of these questions. What is pain and why do we have pain? Up in dose, a number of side effects.
So let's take a look at this before we move on. This might be an article worth reviewing. He hasn't talked about what he should be talking about. Is acute pain different from chronic pain? That's a stupid question at this level. Not one long-term study related to pain, function, quality of life, opioid abuse, or addiction.
Appear with greater and greater frequency, including the risk of things like myocardial infarction and death from overdose as you get to higher doses, even if you're taking them for chronic pain. And that's very frightening and sobering to us. We're going to learn more about what that's done at the national level. So just to finish up, I want to summarize by hoping you can answer each of these questions. What is pain and why do we have pain? What are the differences between acute, chronic, and neuropathic pain? How do opioid analgesics work to relieve pain? And then why are opioid analgesics important as part of our everyday armamentarium for treating short-term acute pain, but more controversial in treating chronic pain? And I'll leave it at that. Now, next up is Dr. Madras. Did I do it right?
That was really pathetic.
Wonderful.
Wonderful, my ass. That sucked. I mean, it sucks so bad I can barely even articulate its severity of suckiness. That sucked. I mean, this guy's the leading chair of pain management at Harvard Medical School, and that's all he knows? That's all. So he had about 20 minutes, and he used the 20 minutes, and that's all he did? That was horrible.
Thank you very much for coming, and thank you, Gina and Harvard Medical School, for inviting me to this important event.
Okay,
The ancient
hold on.
Greeks, we invoke the Greeks again for a
Sorry, who is this
Pain.
person? The Science of Pain Management. Okay, so this is Bertha Madras, PhD, Professor of Psychobiology, Department of Psychiatry, Harvard Medical School. Opioid crisis. So this whole thing is like centered around defending the use of opioids so far. So why are they calling this the science of pain management? This should basically they should retitle this the justification of opioid overprescription.
Thank you very much for coming, and thank you, Gina and Harvard Medical School, for inviting me to this important event. The ancient Greeks, we invoke the Greeks again for a term called pharmacology.
Up in dose, a number of side effects.
I have to go back to the part where they said this was wonderful. This was stupid.
Wonderful. Thank you very much for coming, and
Wonderful.
thank you, Gina and Harvard Medical School, for inviting me to this important event. The ancient Greeks, we invoke the Greeks again for a term called pharmakon. Pharmakon means a medicine, and it means a poison. And I don't think there's a more apt description for opioids than the word pharmakon, because pharmakon can have remarkable effects in relieving acute pain, and it can also produce addiction and pleasure. And both of these coexist in individuals, whether or not they're feeling pain or not. Pain is the number one self-reported medical reason for using drugs with abuse potential, and pain and pleasure centers in the brain are closely allied and linked. Let's quickly go through, as professors always do, they tell you what they're going to talk about. The opioid crisis, the root causes of it, the commission recommendations, and lessons learned for the future. The United States leads the world in prescription opioids. These are the 30 highest, most prescribing countries in the world, and the United States is number one by far. And on average, it prescribes 5 times more opioids than any other nation on average. Why is this the case? And let's try to understand it. It also has the dubious distinction of leading the world in opioid overdose deaths. And in the past year, where we have good statistics, and the United States is...
Sorry, I have to go back and get this. Wow. Well, USA leads world in opioid. I don't even think that's right. Lost an I in there somewhere. Opioid doses? Just call it overuse. So this was Humphreys, Lancet, 2017. Wow. Well, I mean, that's completely consistent with, for example, my personal medical training. So I was in medical school from 2006 to 2010. And this is what we learned. This is exactly what we learned. And so no surprise, assuming correctly that my medical education was representative of American medical education, which I believe is completely accurate. No surprise. I mean, if this is what students are taught, then this is how the doctors are going to practice. Wow. That's interesting.
Number one by far. And on average,
So it should get worse. So, I mean, this is no accident. I mean, obviously, in the United States, a certain company directed by a certain family paid a bunch of lobbyists to pay a bunch of politicians, and they, changed the rules and the laws and the emphasis. And, they wanted to make pain like the sixth or the seventh vital sign, which I think was actually probably reasonable. But they did that not to treat pain, but to overprescribe a certain class of opioid drugs, which then led to this national addiction to those same drugs. So again, you see how the education plays into the profiteering, which plays into the politics, which then feeds the profiteering, which then creates a so-called crisis. But in order to perpetuate the crisis, they have to then pay off elite schools like Harvard to defend the use of the same drugs that are causing the crisis.
prescribes 5 times more opioids than any other nation on average. Why is this the case? And let's try to understand it. It also has the dubious distinction of leading the world in opioid overdose deaths. And in the past year, where we have good statistics from the CDC, we've had 64,000 deaths due to all drugs. Prescription opioids, about 10,000, heroin, about 15, and fentanyl is leading the way right now with regard to the fastest rising number of opioid overdose deaths. What are the root causes that gave us this problem? It is so important to remember that the United States has had opioid addiction due to medical reasons in the past. In the 19th century, we had a very severe opioid addiction epidemic in this country because morphine, which was so prominent at the time as one of the most effective medications that physicians had, was given liberally to many people, primarily to women, and then during the Civil and after the Civil War to men who suffered tremendous injuries. But what happened since that time, since around 1910, is that we, for that period of time and up till very recently, physicians were quite reluctant to use and prescribe opioids for chronic pain. We have a case of generational forgetting. We have a problem of quality science. We had very little training with regard to pain management and opioid prescribing. And we had a gigantic disconnect between addiction services and medical services, so that rehabilitation centers were no longer connected with medicine. And as a result, this giant disconnect led medical schools, medical education to largely ignore the issue of addiction, especially with regard to opioids. Generational forgetting was a big problem. For decades, prescription opioids were avoided for chronic pain because of the fear of addiction, because of the fear of overdose, and because of the fear that there was no good evidence for their use in chronic pain. I have excavated the New England Journal of Medicine in Countway Library, which is right down the street here, and there, especially with regard to opioids. Generational forgetting was a big problem. For decades, prescription opioids were avoided for chronic pain because of the fear of addiction, because of the fear of overdose, and because of...
All of this is true. So, at some point before medicine got completely hijacked, these were the legitimate concerns about opioids, just like with opium. Addiction, overdose, and long-term lack of benefit. Worse than that is the fact that these opioids are not only not effective in the long term, but they actually make pain worse. Let's see if they talk about that. Again, I had some suspicion that this entire presentation was going to be nothing more than a whitewashing of the opioid crisis caused by the miseducation of doctors and groups that want to profiteer, and then they want to turn pain into a national crisis, so to speak. And then when they turned pain into a crisis and they equated pain management with opioid prescribing, then of course that created a drug overdose crisis. So let's see if they can get out of their own downward spiral here. I suspect that they maybe won't.
The fear that there was no good evidence for their use in chronic pain. I have excavated the New England Journal of Medicine in Countway Library, which is right down the street here. And there were examples of publications in the 1920s of people trying to figure out how to surmount and overcome an overdose. And in some cases, they used vinegar to make people vomit. And in other cases, they used a tube that they stuck into the intestinal tract to try to extract the drug. So physicians were aware for 200 years that these compounds could give rise to problems. And then something happened. There was a 5-sentence article published in the same New England Journal of Medicine saying that narcotics are not addictive. when given to pain patients. 5 sentences, and it catalyzed a movement to blame a provider for inadequate pain management, a patient movement that began to advocate for opioids, a huge investment by pharmaceutical companies to train physicians, to train patients, to train pain societies that opioids of certain formulations were safe and effective for pain management and not addictive. 20,000 specific events were sponsored by specific pharmaceutical companies to train people that this was a safe form of medication, ignoring 200 years of history in the biomedical journals. And detailers went to doctors' offices to try to convince physicians to use opioids.
So I suspect that she's obviously got better awareness than the previous speaker. But I think what she's talking about here was specifically, she says pain society here. And obviously that would imply more than one organization. But I suspect that she's specifically thinking of the American Pain Society that apparently was paid off by certain drug companies to really push opioid overprescribing. The American Pain Society was later sued almost to the point of bankruptcy for pushing opioid overprescribing that obviously killed a lot of people. So here, she begins to talk about the Veterans Administration adopting pain as the 5th vital sign. That's kind of retarded. So vital signs, of course, are what doctors and nurses have traditionally measured upon evaluating any patient. And depending on what list you look at, you could find either 5 or 7 traditional vital signs, and then they wanted to add pain as number 5. Again, I don't think that's completely unreasonable. They could have done pain and depression. That would have been more reasonable. But it's only reasonable if they're asking the question in order to intervene in a way that's appropriate for the patient, not just looking for any justification to overprescribe opioids. And that's how this was ultimately employed. You didn't see doctors asking about pain so then they could send a patient to a chiropractor or recommend vitamins or B6 or magnesium or vitamin D. No, it was only for opioids. So, they basically turned a decent idea into another drug overprescribing pathway. And we've seen that before.
Veterans Administration responded by adopting a principle of pain as the 5th vital sign, and they mandated pain evaluation and aggressive treatment for pain. 2 years later, the Joint Commission started to consider pain as a 5th vital sign. The other 4 are blood pressure, heart rate, temperature, and the rate at which you breathe. And there was other pressures to satisfy patients' pain, and some of the reimbursements for individual physicians and hospitals were based on whether or not pain was treated aggressively. So there was tremendous pressure on physicians. And then
Right. So she's obviously more aware of what's going on, again, like I already said, than the previous presenter. But you'll notice how this evolves. So over here, in the early history that she reviewed, doctors didn't want to use opioids for obvious reasons of overdose, inefficacy, danger, etc. And then you can see how the language in the journals started to change. CME started to change because these groups like the American Pain Society were getting funded by opioid companies. And so look how that became policy to the point of, anchoring hospital and clinic accreditation on whether or not they were playing this game. So we went from something that was considered against good practice to it becoming mandatory within 11 years. That's pretty impressive.
And there was other pressures to satisfy patients' pain, and some of the reimbursements for individual physicians and hospitals were based on whether or not pain was treated aggressively. So there was tremendous.
But again, it's not about treating pain aggressively. It's about prescribing opioids. They equated pain management with opioid prescribing.
tremendous pressure on physicians. And then every doctor's office and hospital room had a pain assessment tool placed on the walls. The focus turned to pain management and prescribing of opioids. The healthcare community, their feet were on the fire because of inadequate medical education, because there were no real guidelines for using opioids for chronic pain, because of the fifth vital sign, the patient movement. CMS, the Centers for Medicare and Medicaid Services, were actually discouraging the use of non-opioids for treatment. There were other financial incentives, and the FDA was languid during this initial period. And then as prescription opioids began to tighten, there was in some populations a transition to heroin with no contingency to provide substance use disorder treatment, no contingency to provide medications. During this period of time, opioid...
So she's on the ball. So basically what she just said is that doctors, through poor medical training and poor education, which made them dependent on this model, they overprescribed opioids, they got patients addicted, and then when the prescriptions ran out, the patients who were then addicted had nothing more to turn to other than street drugs like heroin.
Prescribing increased by over 300%, threefold, and we became a nation awash in opioids. So much so, inadequate medical education, because there were no real guidelines for using opioids for chronic pain, because of the fifth vital sign, the patient movement. CMS, the Centers for Medicare and Medicaid Services, were actually discouraging the use of non-opioids for treatment. There were other financial incentives, and the FDA was languid during this initial period. And then as prescription opioids began to tighten, there was in some populations a transition to heroin with no contingency to provide substance use
FDA sucks.
disorder treatment, no contingency to provide medications. During this period of time, opioid prescribing increased by over 300%, threefold, and we became a nation awash in opioids. So much so that currently about 12 million people misuse them. More than 2 million people have a prescription opioid use disorder, means they are addicted to prescription opioids. More than 600,000 people have a heroin use disorder, and everyone who knows these numbers knows that these are underestimates. These are the National Survey on Drug Use and Health, which goes to households, but does not scrutinize individuals that are not currently living. What are the pathways to opioid use disorder from prescription opioids? Very few studies have actually addressed this, but one recently did by looking at people who are in treatment for this disorder and questioning them. How did they get to this point? A small percentage said, a few said, we didn't have adequate pain control, so we kept escalating the dose. Another cohort said, I liked opioids on my initial encounter with them. They really felt good. And others said, I just wanted to use them for psychoactive purposes. I had no pain. And others said, I need relief from emotional distress. And others said, I had a heroin addiction before, and I was prescribed it. The physician did not ask if I'd had a prior history. And as soon as I got the opioids, I knew I liked them. But the scene is shifting. In 2005, 90% of the people in treatment for heroin had their first exposure with prescription opioids. 10 years later, that number is down to 67%, which means more people are starting with heroin rather than prescription opioids. And now fentanyl in 2013 has come on the scene. And if you look at this copper penny, right beside it is the amount of fentanyl that can kill a person. And if you look at the three vials, one of them is heroin, the middle one is carfentanil, and the right one is fentanyl. And that's the amount that is required to kill people. And you can see the amount that can kill of fentanyl and fentanyl analogs is far less than heroin itself. And we had a perfect storm in our nation. The president organized a commission to find solutions to this crisis. And these were the commissioners, Governor Christie, who chaired it, Governor Charlie Baker from Massachusetts, Governor Roy Cooper from North Carolina, former Congressman Patrick Kennedy, and this very short, ancient lady on Charlie Baker's left-hand side. The commission's tasks were quite simple. What federal funding is currently available to treat this, to approach this problem? What is the availability of addiction treatment overdose reversal currently? How can we prevent? What is available currently in terms of prevention, in terms of educating the public, educating physicians, educating them on prescribing practices, and monitoring prescriptions of patients using prescription drug monitoring programs? What is the effectiveness of educational messages for prevention? Are they good? Are they obsolete? What can we do in terms of promoting prevention? And what are federal prevention and treatment programs? And make recommendations to the president. So the commission response looked at every phase of the cycle of addiction, from supply, which is part of prevention, to risk factors, initiation, escalation, addiction, withdrawal, relapse, treatment, abstinence, recovery, lifelong abstinence, overdose, and rescue, and the impact of this on children, on families, and friends. The recommendations could be summarized, and I will tell you that when I started to draw the first outline for the report, I had 253 headlines. And Governor Christie said, kid, he flattered me by calling me kid. He said, kid, we'll never get anyone's ear with 253 topics. We have to simplify. So we simplified and simplified. The recommendations were in prevention, in treatment, in rescue, in recovery, in research, who would do it, and accountability. And that was a very important part of the introduction. There were 56 recommendations. Federal funding, how to streamline it, how to track it, how to make sure that states and local communities are accountable for tax dollars that go to this problem, how to prevent in terms of individuals, youth, and the national media, how to prevent in terms of supply reduction, which is in the purview of the Department of Justice, how to prevent in terms of patient education, physician, alternatives to opioids, prescription drug monitoring program, and pain management, big data analytics, which we had a large chapter on after I spent a great deal of time interviewing companies that have data and analyzed data acquisition in real time compared to the federal government that sometimes lacks 2 years with regard to statistics on overdoses and treatment needs and so forth. What are the barriers to treatment? poor quality of treatment, insurance coverage barriers, inadequate number of treatment slots, inadequate staffing and training, medications-assisted treatment that is inadequate in terms of distribution, and also people in the criminal justice system. How can we help them as well? What are the barriers to rescue? Naloxone availability is one barrier, but the most important part of naloxone rescue is also to ensure that people who are rescued have the option of developing a treatment program for themselves and, as well, access to medications to help tide them over the inevitable withdrawal. Recovery support services for families, for children, halfway homes, support services in colleges, providing housing and employment, and research into medications, which we'll hear about in 2 minutes, research into...
So you see how all of this, look at all of this activity and money, all of this activity, money, pain, suffering, death is caused by this. Is caused by a medical model that teaches doctors to rely on the same drugs that then or later going to be, causing this crisis. So if doctors weren't educated, this is medical education right here. This is medical education. This is what we learned in medical school and medical training. We never deviated from this. And obviously we all had to endorse this model in our behavior. And look at how this becomes this. And none of these people have any education in, functional medicine or nutrition. So even when they're talking about the problem, they can't see their way out of it other than this expenditure of millions and billions of dollars and millions and, hundreds of thousands and millions of deaths, overdoses. All of this chaos and wasted activity comes from medical education that teaches people to do exactly what's going to cause the problem.
Improved pain medications, improved medications-assisted treatment, improved overdose drugs, because naloxone, as much as it is a miracle drug, in some cases is not adequate for fentanyl analogs, which can surmount the antagonism. President Trump accepted all 56 recommendations. I have it in writing. And in terms of prevention, we said the old model of fried eggs on your brain has to be replaced by modern methods of communicating through social media, modern methods of screening young people through electronic devices and others. We decided that all the root causes that related to the medical community, we have to eliminate. And there were many recommendations, 26, to reverse engineer what had been done.
All right, so I'm just going to go back to what she just said, because that sounds like creating a surveillance state.
And in terms of prevention, we said the old model of fried eggs on your brain has to be replaced by modern methods of communicating through social media, modern methods of screening young people through electronic devices and others. We decided that all the root causes that related to the medical community, we have to eliminate. And there were many recommendations, 26, to reverse engineer what had been done in terms of pressuring the medical community and unleashing their degrees of freedom in order to prescribe according to their best conscience. We had a number of recommendations in terms of...
So again, she's trapped within the medical paradigm, but she's at the same time kind of at least she's able to describe its errors. So she said we have to reverse engineer of miseducation and malpractice, basically. That was good.
In terms of compliance with parity laws and reimbursement of the true cost of treatment, quality outcome measures, I can go on and on. We currently have medications to assist treatment. There are 3 FDA-approved ones, methadone, buprenorphine, and naltrexone, but these are terribly, terribly underutilized in our system. Less than 35% of the 14,000 treatment centers in the nation offer them. 60% of rural communities lack a physician that has a waiver to administer buprenorphine. And even those physicians that have been trained in medications assisted do not engage at all. They are not interested in this community. Patient education is critical. The patient has the right to know and the right to refuse that any one of these compounds which can target the mu opioid receptor can kill. And research the alternatives to opioids for pain management, improved opioid use disorder medication, improved rescue drugs, improved devices, and fast-track approval by the FDA. We have to eliminate stigma, which prevents some people from sharing their woes, their griefs with addiction, with their families, with their physicians. What are the lessons learned? The lessons that we learned were that vast sums of money were spent to promote opioids. Millions upon millions of dollars to transform medical care amongst physicians and in the minds of patients that these were safe, effective, and non-addictive. They were promoted for many medical conditions like migraine headache, which they don't work for. There are a number of medical conditions where long-term opioids simply are not indicated. They were promoted as safe and non-addictive. They were promoted without scientific evidence for the use in chronic conditions. Advocates received attention, but the opponents did not receive equal time on the...
no scientific evidence for chronic use. But it still became not only the standard of care, well, it became the standard of care to the point of being used as a quality criteria for, reimbursements of hospitals, etc. I mean, that's pretty remarkable.
Stage of opinion. Addiction and diversion were not anticipated amongst many well-meaning physicians who imprudently prescribed. Illicit drugs flooded the nation, medical education lagged far behind, and government regulations of this very tightly controlled class of drugs failed to protect the public. And so I close with two thoughts. We hear of Michael Jackson and Prince and Anna Nicole Smith and all kinds of people in the entertainment industry who die, and the newspapers lament their passing. But alas, for those who never sing but die with all the music in them, weep for the voiceless who have known the cross without the crown of glory. Oliver Wendell Holmes is one of the landmark. His dad is the one who wrote this. His son was at HMS. I think this problem can be solved with wisdom, resolve, leadership, and adequate financial support. And right now, our budget looks very promising. Thank you very much.
Good evening. My name is Clifford Wolf, and I have the privilege of completing this discussion.
Okay, so here comes the last speaker, Clifford Wolf. Non-abuse liable analgesics. Director, Neurobiology Center, Boston Children's Hospital. Professor, why doesn't he put his degrees up there? So he's either a PhD or an MD, or both. Professor of Neurology and Neurobiology. Well, if he's professor of neurology, he would have to be an MD or a DO. Department of Neurobiology.
Because I've really identified the problem. Dr. Rathmell indicated to us the challenge that he faces as a physician dealing with patients who have acute postoperative pain and chronic pain. He said that he cannot function as a physician in the absence of opioids. And Dr. Madras has clearly indicated to us the perfect storm that we face by the utilization of opioids. So the question then is what to do, and that's something I'm going to try and address.
Yeah, so again, they called this the science of pain management, but it's nothing more than the defense and justification and bemoaning of the medical profession's induction of the opioid crisis.
So what are the problems with existing analgesics? One of the major problems is most of them don't work very effectively. And it's quite extraordinary. The FDA sees as its prime purpose is to protect us by ensuring that the drugs that we take are safe. And that is obviously very important. But they place much less emphasis on how effective they are in treating us. And indeed, almost every drug that has approval from the FDA for the treatment of pain leaves many patients who do not respond to that treatment. And that is a real problem. And so there's a low responder rate. And this is to the extent that for chronic neuropathic pain, for example, something like 60% of patients who get the available drugs are not helped by those drugs. Can you imagine that? So you have pain, you go to your physician, they give you the FDA-approved drug, and 60% of you will not respond. And what's even worse than that is that there are no means to identify who will respond and who won't respond. And there's no research that has attempted to make that link. There are enormous side effects. We've learned about the abuse liability, the tolerance, the constipation, the other features that are part of the opioid crisis. But other drugs have terrible side effects as well. They make people feel dizzy. They reduce the function of their brains in a way that they would rather have the pain than take these analgesics. And so this is something we have to deal with all of this. We have to improve efficacy. We have to improve the responder rate. We have to reduce the side effect burden. And most importantly of all, we have to find a way of overcoming this abuse liability that is part of the opioids. That it is inevitable that those drugs, such as morphine, fentanyl, and others, as described, which act on the new opioid receptor, inevitably have an abuse liability. So how are we going to make progress to make novel and superior analgesics? Well, the first step is to identify and validate new targets. And targets are proteins that exist in the body that contribute to the function of the nervous system, for example. And there's some targets that if we identify them and we could either activate them or inhibit them, we may be able to block those neural processes that lead to our conscious awareness of pain. How to do that? Well, one way is to use human genetics. Not all of us feel pain in the same way. Some of us feel a lot of pain to a minor injury, and others are quite stoic and do not complain when they have major injury. Using twin studies, we now know that at least 50% of that variance is due to our heritability, our genes. If we can dissect out which of the genes are protecting us from pain, this was going to be one way that we can identify new targets, because we can say, here are genes that enable this person to have less pain than that person. Can we pharmacologically mimic the effects of the pain protective genes and eliminate the effects of those genes that amplify and increase the pain? Part of this is, and this is one of the big technology breakthroughs of the last decade, that we can move away from just testing one thing at a time. We now know the entire genome. We know every single gene, and we can scan every gene to see what happens if we either decrease or increase the activity of each gene on pain, for example. And this is now possible, and I'll say a little bit about that. But it's going to require a transformation of the way we do our science, and it's a big science that's going to require a collaborative effort from many individual scientists and many institutions. So we've got to identify drugs, identify targets, and then the next step is we've got to identify drugs that can act on these targets. How to do that? And this is an example of a screen that was run in my laboratory, which is quite extraordinary because this is an academic laboratory just across the road in Boston Children's Hospital, and we are now running industry-scale screens and are beginning to get hits that are looking very promising. And these have to feed on to identification of the potential targets that can interrupt that flow of information that leads to the sensation of pain. And we're beginning to do this both by going for the targets and also conducting what we call phenotypic screens. I'll explain what that is in a moment, because this is going to be a complete transformation in the way that we approach pharmacological discovery.
So you can see that basically he's just reinforcing the same Cartesian model that was exemplified in the early diagram. And I include that diagram in my books, but I include that diagram in my books because I'm trying to show how completely outdated and simplistic it is. And yet this entire presentation is based on that Cartesian model of, pain originating in the periphery and going through the spinal cord and then going into the brain, and upward and downward modulation of that. So these people are still trapped in a model that I already declared was obsolete 20 years ago. And these people are still trapped in the same model, and that's why they can't get out of what they're talking about here.
Until now, the industry has identified targets, usually on the basis of what is known about the biology of pain, and then they run screens with millions of compounds against that target to find a single compound that selectively acts only on that target or nothing else, and then they introduce it into preclinical models and then into patients, and most of them fail. We need a different way, and I'll explain how we can begin at last to do something that will, I predict, transform the entire way that the pharmaceutical industry can approach this problem. One of the problems that the industry confronts when it tries to develop new therapies is how to test novel analgesics preclinically. Dr. Rathmell indicated to us that pain is a subjective experience. We can report it, as he said, and we take it on trust that when someone says they have pain, they do have pain, even though we have no objective measure. And that's true as well when you want to test your analgesic before you put it into patients. How can you test it? How can you see that this new compound that you've made against a novel target is effective or not? How can you evaluate that? And in fact, almost every existing model that is used now turns out to be very poor predictors because we get a whole series of compounds that look very promising preclinically, but you go into the patient and they fail to work. Something is wrong and we have to fix it.
So basically, look at the flow, look at how the medical system works. We educate doctors to depend on drugs that have low efficacy and high risk. Then we create a healthcare crisis based on that prescribing. And then, because of the crisis that we've created in medicine, we then can justify millions and billions of dollars in so-called research that goes to these elite organizations to then look for a solution to the same problem that we created out of our simplistic models. This is precisely how the medical world works. Miseducation, malpractice, crisis, justification for more funding into the same system that created the problem. Miseducation, malpractice, crisis, and then more funding to the same groups that created the problem. There it is.
Well, here's an attempt that we've done. This is an instrument that was built by a graduate student in my lab, David Robeson, that he calls the palm reader, and it enables us to look.
I mean, look at all this technology that's going to go into solving a problem that they created, and they still haven't even mentioned anything about diet, nutrition, lifestyle. They've only talked about neurons. I mean, come on.
Look at the behavior of a freely moving animal. This happens to be a mouse. It's minding its business. And as you can see, there's color on its paws. We can detect the contact of the mouse as it moves on the surface. And this information can be captured, analyzed, and we can use machine learning algorithms to interpret exactly what the animal is doing and how its behavior changes at different circumstances.
Now you have to have machine learning algorithms and artificial intelligence, which is a whole nother, multi-billion-dollar industry, simply to address pain that they've created by miseducating doctors. I mean, most doctors can't think beyond this when it comes to the treatment of pain. And so now we've got artificial intelligence and, machine algorithms to investigate innovative treatments to pain. The problem is here. Here's the problem. And look at all of this chaos that stems from this problem. We start with miseducation, and now we've got billions of dollars to find a solution to the problem that the medical profession created.
We can detect features of this animal's behavior that reflect anxiety, fear, pain, and relief of pain in a way that has not been possible before. And we're very excited to roll out this new technology, which is almost ready for prime time. I mentioned phenotypic screens. How can we move away from just looking at one target at a time? And this is where stem cell technology is going to make an enormous transformation. We can now take cells from the patient, a blood sample, turn them into stem cells, and then turn those stem cells into those neurons that generate the signals that lead us to feel pain. And over there, on the right is an example of a plate of sensory neurons that are those neurons that are activated by intense or noxious stimuli, and they are identical in every respect. They're made in a dish from a patient's stem cells, but their behavior and properties in every respect resembles those of a patient who has a noxious stimulus applied to them. So we can study pain in a dish, and we can now begin to screen against pain in a dish. And this is a phenotypic screen that I mentioned. It's a phenotype, a pain phenotype rather than a target. The colors over here reflect the activity of the neurons. We can not only culture these human neurons derived from patients that are pain neurons, but we can look at how their activity changes, and we can
So like I said before, they're only talking about neurons here. They haven't even talked about glia. So if they only talk about neurons, then they're only going to talk about nerve active agents. So limiting the conversation to neurons means limiting the treatment options to nerve active agents. That's why look at how these people are trapped in this conversation. They're trapped in a conversation and they can't get themselves out of it. That's why they have these jobs.
screen for compounds that can reduce or increase the activity. And again, this represents a completely different way to study pain and to begin to screen for new therapeutics. Here, I mentioned human genetics. There are some mutations in ion channels that produce in some patients spontaneous pain. These are patients who out of the blue will suddenly have very severe pain in their limbs, pain that is so severe that they walk around with buckets of ice and put their arms into them because they cannot stand the pain. The pain is spontaneous and it gets worse with increased heating. We've identified the mutation, we've taken stem cells, we've introduced this mutation, we've made these pain neurons from the stem cells, and we're now recording the activity. In the top row are the control cells that don't have the mutation, and you can see there's less color because they are less active. Normally these pain neurons are not activated unless they're exposed to a noxious stimulus. But in the bottom two panels, which is where the mutation has been introduced, the pain neurons are now beginning to fire spontaneously, exactly as in the patients, where the pain arises spontaneously. But even more so, you can see there's more activity at higher temperatures, which is exactly what the patients complain about. So we now have a phenotype in the dish which copies the phenotype of the patient, and we can now understand exactly what is driving that mechanistically and begin to screen for new therapies that can alleviate this particular phenotype or pattern. How? So that we've dealt then at least with some of the changes that can occur in the way we approach the study of analgesics and pain preclinically. How to test novel analgesics? We get one, we've identified a new target, we've identified new compounds, we've tested them preclinically. How do we now test them in our patients? And again, we run into the same problem. We rely on patients' report. We all know how varied that is. Your pain is not the same as my pain. My pain today is not the same as it will be tomorrow. My pain may be affected by the fear that I have that I will lose my job. My pain may be influenced by the fact that I think that the treatment the doctor has given to me is going to work. In other words, a placebo response. All of these are confounders that make it extremely difficult, and Dr. Rathwell issued the challenge to the audience, how can we measure pain objectively? Well, I'm not going to claim the prize from him because I'm not responsible, but we can use functional imaging of the brain as a readout of the changes in activity that occur in our brain during the experience of pain. This is a recording from a colleague of mine, Irene Abrams from Oxford University, and she is one of the leaders in measuring change function in the brain that reflects the presence of pain or not. And her recordings are so accurate now that instead of doing a clinical study on 200 patients to see an analgesic signal, she can see a signal on 5 patients or less. So again, a transformative change in our approach to the development of new analgesics. So what are the new strategies for developing new modes of managing pain? I'll just give you 2 examples. First is a discovery that was made by a colleague of mine at Harvard Medical School with me. This is Dr. Bruce Bean, who works in the neurobiology faculty at the medical school. And we looked at the challenge that, in fact, Dr. Rathwell mentioned. He said, he mentioned that if you go to the dentist and you get a shot of lidocaine or novocaine, you do relieve pain, but you also block all sensation. You become numb. Not only do you block all sensation, but you block all motor function. You become paralyzed. Anyone who's had an epidural knows that, yes, you get the relief from childbirth, but you cannot walk, and if you stood up, your blood pressure would fall. So local anesthetics they do work, but they have a real problem. And the real problem is that they are non-selective. They act on every excitable cell. They act on motor neurons to cause paralysis. They act on those neurons that generate tactile sensations. And indeed, they act on the excitable cells in our heart and in our brains. So there's what we call very limited therapeutic index. The difference between the amount of drug that you need to get an analgesic effect and the amount that causes unwanted effects is almost zero. How to overcome that? Well, we came up with an idea by saying, well, what is unique to pain neurons? Those neurons in the periphery that are activated by noxious stimuli and whose activity is the trigger for the sensation of pain. And it turns out these neurons have a particular class of ion channels called large pore channels. And that's exactly what they are. When they're activated, their pore is large, much larger than most other channels. And it turns out they are large enough to allow drugs to enter into those neurons. So we said, well, how can we find a way to selectively use this drug delivery device that's only present on pain neurons? And what we did was we took the lidocaine type drugs and we converted them in a way that they were inactive unless they got into pain neurons through these large pore channels. And this is work that has happened here in the Longwood area, and which we are hoping to get a company that will use this technology this year, and hopefully we'll have our first studies in patients within a relatively short period. So this may be one way that we can help Dr. Rathwell. We can wean him off his need for opioids by developing an alternative strategy. What about chronic pain? Well, here's the strategy. Again, this happens to be examples from my lab. There are many other people who are doing other very exciting and important work.
So again, they haven't gone beyond the conversation of simply talking about neurons. limiting the conversation to neurons will limit treatment to those that only function on neurons. Okay, so he just said he's about to get into new strategies for chronic pain. He better talk about glia. And he better talk about glia, or this is just incredible.
Other very exciting and important work. Well, the other strategy was to go back to this notion that we had that if one patient happens to have a mutation in a gene that is pain protective, can this inform us about a potential way of developing analgesics? And this is a study that we published relatively recently where we identified exactly that, a pain protective haplotype, a pain protective variant in the gene, and if you have it, about 2% of us have it, 2 copies of it in both our chromosomes, you are protected from, you still will feel pain when you're pinched, but if you have surgery, you won't require opioids, you'll do much better, your pain reports are less. And we have identified the gene, we have identified the pathway, and are now developing drugs that can interact and mimic the effect of this pain protective haplotype. So what I've given you today is an example of the kinds of work that I've been doing, but we've got to look to the future. And part of what I do is to train the future, people who will take over and develop completely new therapies. So for the first time in my career, I am pleased to say that I have a living next slide, which is one of my entrepreneurs who has come from my lab and who's going to tell you about his strategy, and indeed 2 other former members of my lab who are working on a new way of developing new analgesics.
So again, they're trapped within their own model. This is just a justification for malpractice, and now they're going to talk about how they're going to stay trapped within that model to then justify more drugs and more research dollars. This is exactly what you should expect from Harvard.
Thanks so much, Clifford. When Clifford told me that I have to be a living slide, I realized I have to be very lively, so I'm going to do my very best. So what I'm going to do in a very, very short period of time is give a bit of an overview of the last couple of years of my journey with founding this company, Blue Therapeutics, and kind of what we're up to. I would also like to highlight how the ecosystem at Harvard and the greater Boston area itself has been so instrumental in getting this off the ground, and how entrepreneurship is such an important part of this and piece of this puzzle to realize the very next step.
They haven't even talked about science, and now they're talking about entrepreneurial affiliations within their organization. So this is, again, what you would expect from Harvard. Turn every problem into a profit center.
To talk about the founding story, I think there are a few different layers. The first layer itself is something that our esteemed speakers have all touched upon, which is the tremendous opiate crisis that our country is facing. When we were conceiving of this idea in about 2013, 2014, the number of opiate overdose deaths that were happening were something like 60 to 70 deaths a day. I'm really sorry to report that in 2016 that has doubled to 145 deaths a day. It's a major, major problem where we need to have impact. The second part of it is that in the drug discovery and development process, you can think of it as a pipeline. We first discover a novel strategy, then we develop ligands towards that, but then to take it into the clinic and the market, you have to first show that there's a good safety tolerability profile. From there, you convince the FDA and then start human clinical trials. And then there are 3 phases to the clinical trials as well. The first phase, you look at safety and tolerability in human populations. Then you go on and do a proof of concept efficacy study in phase 2, where you can actually see if it's actually going to work in a small population of people suffering from a particular condition. So what typically happens is that for a pharma company to be interested in a strategy, typically what happens is they get involved when the strategy has already been de-risked a little bit. So it typically tends to be in the phase 2 or afterwards in the clinical trial. But how do we then get it from the point of discovery and get it all the way to that phase 2 step? And that's where I think entrepreneurship has a major, major role to play. And myself, Michio, and David, we were all in Clifford's group at this time, and one of the ideas we had was, let's live this dream of trying to actually have impact on this profound problem. And then we focused on technology that I developed during my PhD with Phil Portuguese, who's also a co-founder and the scientific mentor for this company, and I'll talk a little bit about the technology itself. Very quickly summarizing what we already have, the other speakers have done a phenomenal job with this already, but just to mention a key point, all of the opiates that we've heard about and that have been used, like morphine, heroin, fentanyl, carfentanil, all of them target an individual and a single opioid receptor called the mu opioid receptor. So this opioid receptor is involved in a phenomenal process which does cause pain relief, but it also projects into different brain regions which lead to the side effects like withdrawal, like addiction, and also the main reason why people actually die during overdose, which is depression of breathing. So what we set out to do was some new research that had come out showing that receptors actually need not exist as individual receptors, but they may actually couple with another receptor physically to form a dimer. And we got very interested in this, and our idea was, can we do a systematic screen to identify ligands that would target different heterodimeric receptors, and that way delineate which dimer leads to, let's say, pain relief, and which maybe leads to some of these horrific side effects. So if we can separate that out, maybe we can develop targeted therapies that would only cause pain relief but would not have those side effects. So that effort led to our lead molecule, Blue 181, which essentially is a non-narcotic and very effective painkiller because it's 50 times more potent than morphine. So that means we need to use 50 times less of it because they get the same amount of pain relief. But it does not have any of the common opiate side effects like abuse potential, constipation, most importantly respiratory depression as well, and also almost no tolerance. So these are some of the major facets of this that makes what we're doing very interesting. So what we're doing currently is moving this from out of that discovery phase and getting it into safety tolerability trials, so that very soon we can file the IND and then start our phase 1 human clinical trial. So that's kind of where we are as a company. And just to highlight again how important this whole process is and how this ecosystem has really helped us. First of all, Harvard Innovation Lab, took us in as and incubated us with them. So that was again very, very powerful. The second part of it was also, the Dean's Challenge between the medical school and the business school, and how that really helped and gave us the expertise that was needed to kind of move us along. And finally, I'd like to thank, all the funding agencies like NIH, Department of Defense, and all of them who have given us the funding to get this off the ground. With that, thank you very much. I also want to just say, even though Clifford was not associated with this work, he's been so instrumental in guiding us and mentoring us on this journey. So thank you all for listening. I appreciate it.
So we now have an opportunity for our panel to answer some of your questions. I'll start with a question to Dr. Rathmell. As an anesthesiologist, what do you think is your role in combating the opioid crisis?
So, my microphone's on. So as a traditional anesthesiologist giving anesthetics for surgical procedures, I think that we have a tremendous role to play in reducing the need for opioids. Even during major surgery, we've really put together what combines a wide range of different non-opioid analgesics, often coupled with peripheral nerve blocks that can reduce pain after surgery, regional anesthesia. And it turns out that we've developed protocols that can reduce or eliminate the need for opioids even after a lot of major surgeries. As a chronic pain specialist, it's very different in the clinic when someone has persistent pain associated with a chronic pain condition like chronic low back pain or pain toward the end of life. It's really having frank discussions about what the role of opioids is and minimizing the number of people that are started on new doses of opioids and then minimizing the maximum doses that they reach. So I think there's two roles depending on which hat I'm wearing.
Dr. Madras, what has been the biggest impact on the opioid crisis of the involvement of the government?
I think there are three ways the government has pioneered in the past year. One is to organize a commission that would design a roadmap for how to alleviate the crisis. Number two is to declare this a public health emergency. And number three, based on my insider information, is to summon all the cabinet secretaries and involve them intimately, daily, in what they're going to do in terms of action plans related to our 56 recommendations. And I've seen that in action quite frequently recently.
Dr. Rathmell, a patient, one of our audience asks, what is the likelihood that this individual as a patient could develop tolerance addiction from postoperative opioids, say for hernia or surgery or appendectomy, and should they refuse opioids and ask for NSAIDs instead?
So the likelihood that short-term use will lead to persistent use down the road is extremely low. We've done this is the heart of my current research. For instance, a woman who comes to delivery and has a cesarean section and has never had an opioid before, gets a dose or two or three for the first several hours after cesarean section, has probably about a 1% chance of still using those opioids a year or more after surgery. It's quite low, but 1%, 1 in 100, that's not zero. Should you refuse opioids? Well, I think you should have a frank discussion with your anesthesiologist or the treating surgeon and say, are there ways that I can minimize my opioid use or even eliminate it? Because in many of the major surgeries we've had, including cesarean section, we've come up with just superb strategies for avoiding.
When I was working in hospitals in postgraduate training, we gave out opioids like candy and with zero discussion of any risk. So that's how we were trained. We were trained to give out opioids as if they were, like Pez candies.
Them all together without having to suffer through it. I don't think you should suffer in silence. There are alternates to opioids in most circumstances.
Related to that, please, both of you answer this. How long does it take for a patient who's taking opioids for treatment, for legitimate treatment, to become addicted?
But the answer is, we don't know. Can a single exposure lead to such reinforcing effects that people go back and experience it? But certainly we know from both alcohol and opioids and many other drugs of addiction that someone who's never exposed but has a predisposition doesn't develop the disease of addiction. So a single exposure, it's not out of the realm of thought. But we also know that millions of patients receive these drugs every year and do just fine without going on to addiction, and they're extraordinarily effective for treating pain.
Mm-hmm. Well, there is some evidence that people who are treated with opioids for longer than 7 days are much more likely to continue using them for months and even longer than that. So there is, among many state governors, a desire to limit opioid prescribing to 3 days or 7 days for acute pain, and then wait and see what happens after that, rather than giving a month's supply with an open-ended refill possibility.
Well, I'm going to counter that real quickly, because the problem with the 7-day rule is that all painful conditions are not created equal. Someone who has a major spinal surgery, for instance, with instrumentation, we know the course of resolution of pain is weeks and weeks. And sending that person home with a 7-day prescription is just a license. It's just, you're going to fail. They're going to return to the emergency room. They'll have a horrible, horrible experience. And so we have to tailor what's needed to the magnitude and duration of the experience.
This is a conundrum, of course, and I'm not going to counter, but one of the root causes of the 30 that I've excavated is the fact that with the current financial accounting and hospitalizations, many people have been released from hospital very prematurely compared to what they used to be released in time, and released with hefty doses of opioids so that they don't have to come back, rather than caring for them in a hospital setting where they would receive adequate nursing care, adequate pain relief, and then go home when they no longer were in acute phase post-surgically. Yeah. This has happened, and that's probably a very small but significant reason why we have fed this problem.
Yeah. So the next question, again, both of you, is whether addiction incidence differs across age, gender, and race.
That's easy.
Yes.
The younger you begin using, the much likelier you are to become addicted. I don't think that principle can be disputed for every class of drugs, which includes alcohol, tobacco, marijuana, cocaine, opioids, anxiolytics, inhalants, stimulants. That principle holds for all. And one of the most important things, I think, in terms of prevention is choosing not to be exposed to drugs with addictive potential at early ages.
Here's a challenging one. Does pain shorten lifespan?
Mm-hmm. I mean, that's so broad as to be... pain.
Let me answer in the flip way. I mentioned human genetics as being one of our ways of interrogating the role of different genes in the generation of pain, and mentioned an example of a mutation that causes spontaneous pain. But there are mutations that completely eliminate our capacity to feel pain, and these are patients who have what we call congenital insensitivity to pain. They don't feel any pain. In consequence, if they go to a Starbucks, they can't tell the difference between a coffee that is pleasantly warm and scalding hot. and when they eat, they can't tell the difference often between food and their tongue. They chew their tongue, and their life expectancy is reduced very substantially.
So you'll notice that throughout most of these conversations, they just go into these absurd tangents of these, 1 in a million conditions and 1 in a million gene mutations. Again, this is typical of the so-called elite organizations because they have to just detach from reality. And this is, even though they're talking about things that are real, it's still a relative detachment from reality.
Because if they have a fracture, they don't report it. If they have appendicitis, there's...
This is just bullshit. Again, they're talking about stuff that occurs in like 1 in a million or 1 in 8 million people, and why are they talking about that in this context?
No clue. And so pain, the early warning mechanism that Dr. Rathwell highlighted, is something crucial, and we have to preserve it in our treatments. But the reverse question is more difficult.
So I would say that the consequences of severe persistent pain are devastating. They're absolutely devastating. So we talked about the limitations in the treatment. I go to clinic, every time I'm in clinic, I face someone who's suffering with very, very real pain with a very, very real cause that we cannot get to the root of. And that has consequences on people. And yes, it probably shortens life. And yes, the suicide rate is dramatically higher in those who suffer chronic painful conditions. So it has profound consequences. I'm not here to say, don't use opioids, because I have that conversation all the time. But what then? They work for short periods of time, but what then? And we don't have answers to what then.
And that is the motivation to find.
So look at what he just said. He said, we don't have answers. He said, we don't have answers basically beyond our current model of being trapped. These people are incredible. I would love to have these jobs. I would love to be, the dean or whatever, the chair of chronic pain management at Harvard. Give me that job. But look at how these people are trapped in a model. They're trapped in a drug model that's based on the neuronal model of pain, and they can't see their way out of this model, and then they admit that it doesn't work, and they still can't get themselves out of it.
Consequences on people. And yes, it probably shortens life. And yes, the suicide rate is dramatically higher in those who suffer chronic painful conditions. So it has profound consequences. I'm not here to say, don't use opioids, because I have that conversation all the time. But what then? They work for short periods of time, but what then? And we don't have answers to what then.
What then beyond opioids? He says we don't have answers.
And that is the motivation to find. So related to them is the question whether there's a danger of taking NSAIDs or Tylenol regularly over long periods of time. Is it truly a safer alternative?
Well, so that's a hard question to answer because it's very contextual. So I think for the acetaminophen, it seems to be an extremely safe drug all the way up to the extremes of life if you stay under a certain dose threshold. But if you start getting above 4 grams a day, particularly if you drink alcohol concomitantly, there's a pretty significant risk of liver injury. So that's acetaminophen, very, very safe at the lower doses. The non-steroidal anti-inflammatory drugs like ibuprofen are also quite safe, except for very specific populations where it inhibits important mechanisms that lead to proper blood flow to the kidneys, for instance. So if you're someone who has a terrible congestive heart failure and is on lots of diuretics, and you take even normal doses of non-steroidal anti-inflammatory drugs, you risk very significant kidney injury. And same thing goes for people who have a predisposition to complicated ulcers and so forth. So there are at-risk populations for the NSAIDs, but by and large, if you're young and healthy and use over-the-counter doses of non-steroidal anti-inflammatory drugs, they're quite safe.
Dr. Madras, do you see a place for marijuana in the management of pain?
Glad you got that.
What are the risks that may involve?
Well, certainly we don't.
So Mr. Pain Management just said that NSAIDs are remarkably safe, even though what he didn't say is that they're one of the leading causes of death in the United States, and they kill, I believe, hundreds of thousands of patients per year. And then his summary that he just gave was that they're remarkably safe.
Have good data on the use of marijuana. We have 4 randomized controlled trials on the use of marijuana in neuropathic pain. The trials lasted just a few weeks, and every subject except for a few were not marijuana naive, so they knew precisely what to expect. With regard to long-term use, we don't have the data on what the effects of chronic daily and more frequent than daily use of marijuana is on quality of life, cognitive function, addiction, and all the other outcomes. We do have evidence that people who use marijuana for chronic pain have higher rates of opioid misuse, prescription opioid misuse, and opioid addiction, and people who use marijuana also have higher rates of opioid addiction and opioid misuse. We also know that people who are in treatment for opioid addiction and use marijuana have much higher dropout rates from their treatment, so that the evidence at this point weighs on the side of marijuana not being a good solution. The evidence also weighs on the side of there being no FDA approval for the whole plant, which is completely unregulated in terms of dose, in terms of ratio of THC to CBD, in terms of quality, purity, and specific indications and long-term outcomes.
So all of that is just the typical medical bullshit. Stating that we don't have the science, we don't have the research, it's not FDA approved, all that's just bullshit. cannabis has been used by humans for hundreds of years, or if not thousands of years. And so at any point in time, they could have figured this out if they wanted to figure it out. That's just all bullshit.
In summary, I'm not a fan.
We have 100 other questions, which unfortunately we are not going to be able to. One of them seems to be as long as War and Peace. But there's one question here, which I think we can all have a little bash at, was what was the reason that you, all of us, chose this field of study?
Well, that's very easy for me. When I was an undergraduate at college, I was 16 years old, and I was in biochemistry, honors biochemistry, and our professor gave us a choice of 10 topics to choose to write a lengthy research paper on. And I didn't like any of the topics, and I went and I said, I'd like to pick my own instead of what is in this list. And I searched the literature and found a disease called phenylketonuria. And phenylketonuria is an inborn error of metabolism, which is caused by having a genetic deficiency in an enzyme. If the disease is not detected right after birth, the child goes on to develop a very serious brain disease, depending on their genetics, some not so serious, some very, very significant brain injury. And if it's detected and they're put on a phenylalanine-free diet, they can go on to live a normal life with a normal IQ. And I was mesmerized by this paper, and I said, if we can understand the brain and understand what errors there are that make a brain go awry, we can change the course of the life of an individual in such a dramatic way. That was it. That was my moment in life. And from then on, the brain was my calling.
Oh, I get a chance here, okay. I went into anesthesiology because I very much like seeing science in action. In the operating room, the goals are clear. It's really producing a pain-free state without recall and taking care of patients in that very acute setting. It's very appealing. I call it science in action. It's like when you do experiments in the lab. It's that they actually do the experiment. You give the drug, you see it work. But what I lost from my medical training was the long-term relationship with patients, and that's why I ventured to chronic pain, and eventually from primarily anesthesiology to all chronic pain for a large portion of my career, including pain in those near the end of life, which I very much enjoy because of the challenges and the extremely intense interactions with patients where you can really make a difference in their lives.
So for me, my experience as a medical student training in South Africa, at a time when the South Africans were still remembering the opioid problem and did not prescribe opioids for post-operative pain management, as a medical student, I went into the post-operative recovery, and all the patients were screaming and crying and in terrible pain. And I said to the surgeon, what's going on here? He said, well, what do you expect? We've had surgery. And that was the attitude.
Wow.
And I just said, this is wrong. And that was my turning point when I decided to devote my life to understanding pain and helping develop new medications. Thank you all. Thank you all. We look forward to a new future.
He looks forward to a new future of doing the same stuff over and over again to justify his funding and perpetuating the problem. I mean, this was perfect. This was perfect. This was perfect from Harvard. You would expect them to identify the problem. The problem is we miseducate medical doctors about what pain is, what perpetuates it, etc., and how to intervene. We give doctors these, how many options here? 5 options. We give them 5 options for the treatment of pain. And then when those don't work, what do? We use higher doses of the same thing that didn't work. Just like a booster for a shot that didn't work, we use higher doses of drugs that didn't work in order to pretend that we're going to get a better benefit without more damage. That was exactly and precisely taught to us in medical school. What we were taught in medical school was and this is almost a direct quote from our neurology professor. He said, he was talking about the treatment of epilepsy, but it applied across the board. He said, you keep pushing the drug until you get toxicity or efficacy. That was such a brilliant statement to exemplify the medical model. You keep doing what doesn't work until it either works or the patient dies from toxicity or adverse effects, or they drop out of treatment. So-called dropout. So a patient who drops out of treatment is a patient who either got better, went to a different doctor without telling the investigators, or couldn't handle the adverse effects of treatment anymore. So again, that was exactly word for word quote what we were taught in medical school from our neurology teacher. He said, you keep pushing the drug until you get toxicity or efficacy. And that's exactly what they're doing here, with a few nuances and the justification of millions and ultimately billions of dollars in artificial intelligence and machine learning and rat models and looking for mutations and all this stuff, because they're trapped in this model. This is amazing. This is stunning that this is the level of conversation from Harvard in 2018. So, obviously I took a few notes here. and I'll integrate that into the upcoming updates. But that was horrible. I mean, the science of pain management, I mean, this is just stunning. So I'll end my commentary there. Thank you very much for your attention. I'll get this on the website as soon as possible without any edits. I think that this was a successful attempt at this kind of platform or model of looking at videos, because you'll notice, including my commentary, I was able to review this video in an hour and a half, and the video itself is an hour and a half. Because we watched it at double time, that allowed me time to make my comments, even though we're still within the exact same time frame, precisely an hour and a half of the original video. So I think this worked. I'll try to do this again in the future. And hopefully we'll see a video that provides us something of more benefit. But for example, everything they said here in 2018 is exactly what I learned in medical school, and I started medical school in 2006. So this represents, again, precisely what I would have expected. Zero advancement in the clinical management of pain over, the past 18 years. Wow, that's amazing. Okay, well, that's the end of my commentary. Thank you very much. See you soon.